Hello, everyone, and welcome to the very first Ananda Developments. I think we're going to call this In Conversation. Our very first guest is Dr. Dupe Burgess. She runs Bloomful, which is a digital platform for women's gynecological health. Welcome, Dupe.
Thank you for having me, Melissa.
Absolute pleasure. We met, for everyone listening, we met, as many people do, on LinkedIn. Probably, it must be a year or so ago now, and I was watching you talk about your platform, and it was really interesting. We've had a couple of conversations about the work you're doing, about the work we're doing. When we decided at Ananda we were going to do these conversations, you were at the top of my list. So here we are. So I'm sure we'll get on to your platform a little bit during the process of the conversation, but I do want to dive straight in to get to the guts of it. Starting sort of at the macro, where are we at with women's gynecological health sort of globally? Are we on track, off track? And more important, or more interestingly for me, is are there differences in the first world economies or the Western economies and other economies? Are we different in the UK from the US? So do you sort of have a bit of an overview of where you think women's health is, and gynecological health is positioned at the moment?
So we're in a transition period. I think that's we are in a time where it's becoming much more mainstream to talk about women's health. It has various names depending on the industry, femtech in the startup world or in the tech world. So we've started to sort of attach these labels to it. And it's started to become a more widely consumed conversation across all channels, whether it be in the tech space, which is where I play, or online. Yeah. Your question about where we are, it's not a straightforward one. There's quite a few different dimensions. There is the education, and there's the knowledge and the understanding around these conditions. There is getting the right help, the accessibility, the healthcare structure that is required for that. There is getting the right diagnosis, which is pretty much a function of doctors' knowledge, as well as the level of research that's been done into these areas. And then there's getting the right treatment, which again kind of depends on research and trials and drug R&D. So it's very multifaceted, I would say. And I think the positive headline beneath that is that we're moving in the right direction generally as a global population. I think it's fairly accepted that we as the UK and as the Western world are going to have much better health infrastructure in general than many parts of Africa, for example, or other parts of the less developed world. And I think for me, the biggest comparison is not necessarily country by country, but it's more kind of condition by condition. And the way that I look at this problem is more about when you compare to non-women's health, in inverted commas, condition. Things like diabetes, epilepsy. We've got really structured, really streamlined ways of getting to the diagnosis fairly quickly, getting the right help, getting to the right specialist, getting the right treatment. We've got lots of R&D going on in other areas of medicine, whether it be cardiovascular, endocrinology. And what we see is a really big delta, essentially, between other parts of medicine and this particular area. That's really the crux of the problem. I don't think that's any different really anywhere else in the world. I do think that when we look at somewhere like the US, it has a different healthcare structure to the UK. It's got its problems, frankly. And I think the biggest thing there is that, we're seeing things like rising maternal morbidity rates year upon year over the last couple of years, and that's starting to become a big topic.
Wow.
Right. So I think in answer to your question, the UK is lucky in so much as that we have infrastructure that generally is in place, and whilst it's huge pitfalls, works for most of the population. And that is very different from other Western populations. But I think as a whole, we can do better in moving women's health forward in so many different areas.
So why do you think it now is sort of on the radar and we're talking about it? Is it because of developments in science and research, or is it because there have been a lot of women who are absolutely fed up, specifically talking about, say, endometriosis? Is there just a groundswell? Was there one woman who said, you know what, I've had a gutful of this, I am literally and figuratively, and I'm going to stand up? And so does it come from the advocacy side, or does it come from science, or is it kind of not either or?
It comes from advocacy side. That's my feeling. I think we're living in a time where women have got the loudest voice that they've ever had throughout history. You know, we've got much more influence on healthcare and the state of play, and I think women in general are demanding products more and more that really cater to them, and they're not settling for less. And I think I'm not a huge fan of social media in general, but the one thing that has come out is just the ability to project voices in the right direction. And we've seen that over the last couple of years. It's being spoken about, as I said, as much more of a mainstream discussion in every different dimension, whether it be the workplace, we're becoming much more aware of the impact of women's health on productivity, for example, absences, absenteeism. We see it played out in government. We know that the government is very focused around the UK government, very focused around women's health agenda and how we experience. And I think globally, I think globally, there's a bit of an uprising happening, and that's really the crux of it. Now, I don't think that's translated well enough into the research side, and I think that's the bit that we're really lagging behind. Research, development, but also ensuring that the actual healthcare that women receive on the ground fits their needs.
Yeah, fascinating. Now, I have an order of things I'm going to talk to you about, and I'm actually going to change that, because you've touched on what women are demanding. And I was speaking to someone the other day, and she was explaining to me that there'd been a piece of research done, I think it was 2017, around there sometime, and they spoke to thousands of endometriosis patients and I think thousands of clinicians, and they asked them about their priorities. What they found was that the priority of people in science was to find a biomarker that would, and you're going to explain to me what a biomarker is, and a biomarker that will indicate that there is endometriosis. So as I understand it, that means something that will tell you that endometriosis is going to be there. And what women wanted who have endometriosis is something non-invasive that will help deal with the pain of endometriosis. And I went, whoa. So actually these two groups need to talk to each other, because yes, we definitely need a biomarker, but we also need to deal with the reality on the ground at the moment. So can you explain exactly, obviously in terms that I understand, what a biomarker is and why that would be so important to science, and then why women are saying, actually, for something like endometriosis, I just need you to help me with the pain?
A biomarker is any targeted element of the body which very much pertains to the condition. So, for example, it could be a particular gene, it could be a particular cell in the blood. The reason it's important is because once we understand the biomarker that specifically pertains to a condition, that's the foundation of drug development around that condition, because you develop a drug around targeting a specific biomarker. And I think it's interesting what you've just said, because drug development is a cash cow, essentially, or it can be. That's the commercial side of medicine, developing a drug, selling it, finding ways to make it needed in different ways. And from this study that you've just said, shows the misalignment in incentives between commercial work and women's needs are completely different to the medical and biopharma industry. And I think that's a shame, because really we're not going to push forward with treatments for things like endometriosis until there is a shared incentive there and there's a common denominator. You mentioned that women's priorities are more around, was it finding the right diagnosis?
No, well, I think diagnosis was really high, but the number one was give me a non-invasive way to deal with my pain. Yeah. So just make this go away. That's not steroids or necessarily hormones or, the current treatment. If I can deal with the pain, then I can sort of move on to thinking about how I deal with the rest of this condition.
And it kind of makes sense, because pain is, it can change and alter the way you move through the world. It can have a huge impact on your mental well-being, your quality of life, your ability to work. It's distracting, it's tormenting, and we speak to women every day that they just need that taken away so they can think straight. We do have methods of managing pain and managing different elements of endometriosis. I think one of the cruxes from my discussions with women with the condition is that we need ways of actually, getting rid of this from a root cause rather than necessarily managing a symptom. It's also about what is endometriosis about, and how can we actually stop it and stop it spreading, kind of increasing in our bodies. How can we prevent it even, or how can we really get to the root cause of management for this condition in a way that doesn't necessarily involve hormones as well? We know, I talk to women, they don't want to have to be on contraceptives for the rest of their life to manage this condition. I think there's an alignment that has to take place between the commercial pharma world and the needs of women, and that's the sections where the gap is at the moment.
Yeah, and of course I focus on endo because at Ananda we're providing the formulation, a CBD formulation for a clinical trial into treating endometriosis pain that's being run by Edinburgh University. So I've moved this conversation very quickly to endometriosis, but so I suppose going to your experience with your digital platform of women's gynecological conditions that you're dealing with on the platform and talking to women about, is endometriosis a big part of it? And I'm asking my questions in twos, and I think we probably then should maybe go back even a little bit further and say, can you just explain what endometriosis is?
I'm happy to explain endometriosis, which, by the way, many doctors don't understand themselves. But essentially, the condition is where tissue that is very similar to the lining of the uterus. So in the uterus, which is the female sex organ, there is a lining called the endometrium, which is, as in all parts of our body, a very specific cell type that is localized to the lining of the uterus. In endometriosis, those particular cells are found in areas outside of the uterus. So that could be on the outside of the uterine wall, it could be on the fallopian tube, it could be on other organs even, so your uterus, your bladder. And what happens is, as women go through their menstrual cycle, and of course those are the cells that eventually shed and cause bleeding, that same process happens in all the cells, even if they're outside. As you can imagine, if you're having blood cells that are not being sort of encapsulated in your uterus and coming out through your vagina like they would usually, if that process is happening outside of the uterus, it can cause intense pain, menstrual pain and period pain, which typically is during your period, but can actually happen outside of your period. So it can be non-cyclical as well, and it can be really, really quite intense. This process can start from the first period that a girl has, and it can last all the way through to menopause. And I think there's evidence to say that it actually occurs or can kind of persist beyond menopause as well. So it's a really kind of distressing condition for many women. The condition that's personified by pain. We're not clear on what causes endometriosis. I think there is some research around whether it's more genetic, whether it's an immune condition, but I think to the point around the person you spoke to, it's because of the nature of the actual pathophysiology, this can actually affect any organ. So rather than it just being localized to your pelvic, actually become an issue where you're having constipation, or you're not able to urine properly because of these deposits. It can affect your lungs. We hear about women who during the cycle they're actually bringing blood up. So this is something that can affect any part of your body pretty much, and obviously it hugely impacts women's well-being. In terms of symptoms, I've already mentioned very, very painful periods. Pain can occur between periods, but also painful intercourse, pain during and after intercourse. Obviously, it can have a huge impact on your ability to get pregnant, your fertility, your ability to maintain a pregnancy. And there are lots of psychological sequelae as well. So from depression, low mood, poor outlook on your life. I've talked to women who have dropped out of university, out of school because of endometriosis. That's the condition. And also just to highlight, it's not an uncommon condition. Every single person will know someone that is affected by endometriosis.
I've really noticed that the sort of, the degrees of freedom. And when we first achieved this trial that we're doing with Edinburgh University, one of the conversations we had internally is, most of the stockbroking world, when we're raising money, is sort of men, and so they're not going to understand. And the first meeting we went to, one of the guys, honestly, he nearly cried in the meeting, and he put his pen down, and so we went, whoa. And he said, my sister has endometriosis, she hasn't been able to have a baby. And so I went, okay, so actually this is not just a women's issue, this is an everybody's issue. And it was moving, and it was really instructive that actually the first person in the commercial business capital raising world who responded to our story was a man talking to us about his sister. So it is amazing.
It is.
And before you talk about what you're seeing on your platform, one question. So when the cells shed, if they're, for example, attached to an organ that's not the uterus, where do they go?
That's it. They don't go anywhere. They kind of shed, and they end up in the cavity of your, other areas of your body, and they stay there. And that's what causes the pain. It causes destruction to the organs over a period of time. And by the way, if we're not managing endometriosis early in a woman's life, or as soon as we can, those cells proliferate. So over the course of time, those areas become more and more affected, and then huge destruction.
And so then, what are you seeing on your platform?
So we see a lot of women with pelvic pain, endometriosis. It's a very, very common condition. They say 1 in 10 women have endometriosis. My feeling is that anecdotally, it's probably more than that. We see a lot of women coming to Bloomful with pelvic pain, different forms, but also all of the other symptoms that go alongside this diagnosis. I think the things we see, or I guess their motivations for coming to us, or their needs, really vary. But the general themes are around, first of all, just getting heard and listened to. That's a real problem. Not having the time and the space to really express what's going on and how it's affecting your life. And I'm talking about not only with health professionals, where you're sort of churned through a GP's appointment in 5 to 10 minutes with not enough time to really explain the impact, but also in the workplace. Taboo around being able to talk about this and how it's impacting your work and impacting your progression through work. So I think just not being given the time and the space to express what this is doing to their lives. And then the second thing, and I think you alluded to this earlier, just managing symptoms, managing the pain in a way sustainable, in a way that, obviously we can talk about different types of painkiller, but actually being given those options, knowing what those options are, having the education and somebody there to really guide you through that process is something I think the third thing is getting a diagnosis. Many women, and especially in an age where there is a lot of information online, have a suspicion that they have endometriosis. They don't necessarily have a diagnosis. So finding less invasive ways to make a definitive diagnosis that doesn't involve hormones is a really big issue in this space. The hallmark of diagnosis is actually through what we call laparoscopy, which is where small incisions are made in your pelvis and cameras are put through, and it's all done on visibility. I think that's barbaric that we don't have a way of really diagnosing this. It's definitively.
Can you ultrasound?
Ultrasound doesn't pick up these things. MRI is better, but try getting an MRI on the NHS. You're going to be waiting. So we have this issue with the diagnosis, and that does come through patients at Bloomful. And I think the final thing is about fertility, because not enough is talked about how this impacts women's ability to have children. Not everyone wants children, and that's fine, but there are lots that do and can't. And we know that, I can't remember the statistic off the top of my head, but a big proportion of women who are struggling to conceive have endometriosis. So we take on a lot of those patients, we talk to them, we try and guide them through our process, and I think women are just grateful to have a platform to really go deeper on this issue. I should also say another theme that comes out is the lack of more lifestyle, less medical and more lifestyle management options. A lot of women want to know, how does my diet affect my endometriosis? How does exercise affect it? Is it yoga or Pilates I should be doing? And they don't have that information. There's not enough validated research into those things, and that's they don't talk about them. They don't recommend things. And in this day and age, I think there's a real drive towards less medicalization of things, and just less intrusiveness, and use what we have and the tools we have with our diets and exercise to really try and manage conditions.
No, that's absolutely fascinating. So what's the standard process? So if a woman at the moment, so if you just go standard NHS, if a woman thinks she might have endometriosis, what's the process?
So GP is the first port of call. They're the gatekeepers to most of the other healthcare services here in the UK, at least. So you try and get an appointment with your GP, which, as we know, that's becoming more difficult now than it ever has been before in any case for any condition. But that can take weeks, and then once you've got your GP, I think there is the sense that you kind of cross your fingers and hope you have an empathetic one that will allow you to kind of express what's happening and understand it and really point you in the right direction. The typical way it's managed in the setting is that, depending on what the doctor's presented with and what your symptoms have been and how long they've been going on, if you don't have a diagnosis yet, but there is a suspicion that you do, the first thing that you would probably do is call oral contraceptive, because there's the idea that if your symptoms improve on the combined oral contraceptive pill, that's a big indicator that what you have is endometriosis.
Okay.
So you might be given the contraceptive pill, if you're eligible for it, for 3 or 4 months to see how it goes, and if that does help, then often that's the sort of indication that this is very likely to be sort of managed conservatively. If it doesn't help, other things that can be done are, of course, an ultrasound, because whilst it doesn't necessarily pick up endometriosis, it can rule out other reasons why you might be having very severe pain. Of MRI, as I mentioned, is better at picking up endometriosis lesions, but it can be quite difficult to get. Third is referral on to secondary care services, depending on, again, how severe the symptoms are, how long they've been going on, how well managed they are. And by the way, I didn't talk about kind of pain relief, which is obviously kind of all of this as well. I can talk about that more in a second. But going into the secondary care service is a way to get in front of a gynecologist, and the way that they will make the diagnosis is through laparoscopy, which is an invasive operative procedure. We're not talking about a quick scan in 10 minutes. We're talking about coming into hospital, essentially being put under general anaesthetic and having cameras put into your pelvis. And if there is endometriosis there, what they can do is essentially remove the lesions, either by scraping them away or by lasering them. I'm not a surgeon, so I don't have like the detailed amounts of that process.
I'm grateful for that.
But you know that quite often, what I've heard anecdotally is that whoever the surgeon is, unless it's really an endometriosis specialist, quite often areas of endometriosis are left behind, or even if it's microscopic, and what happens is over the course of time that proliferates again. And it's actually,
so is it sort of like a little seed, almost as if the seed is still there, it will grow again?
Exactly. It's a little bit like going to get cancer removed. And I don't mean to liken it specifically to cancer, but it's the best analogy in so much as if you don't remove the whole thing, it can sort of proliferate again. And often we have been on a waiting list for laparoscopy for months or years. They've had it 3 or 4 months later. They're pretty much on their way back to square one. So it can be really difficult for women. And taking a step back into the sort of the world of GPs, they can often, obviously, as a first step alongside oral contraceptive give you pain relief, and that can come in a few different forms. So obviously over-the-counter medication, paracetamol, ibuprofen, and then you've got slightly stronger medication, so things like codeine, and then you've got things like the non-tablet form of medication, so TENS machine, hot water bottles. Lots of women try get a lot of results from those.
Is there any one thing that you've seen on Bloomful from the feedback and your experience that is the best thing that a woman can be doing?
So the short answer to that is no. It's not. There is no one. There's no one answer, unfortunately. And even worse, there isn't any guidance, or there's no cohesive or collective understanding or recognition of what even a few different things are. You know, it's with these women, it's trial and error, and they go through a lot of they go through many weeks, months and years of trying different things, managing as best they can. You know, obviously there is the pain relief side, and I think again it comes down to each individual will respond differently to all of those different things. And then of course there is the lifestyle side. So from nutrition to exercise, there are bits of evidence to suggest that, for example, having more of a plant-based diet, and I think it's Pilates over yoga. I might have got that the wrong way around. But apparently is meant to be better. And then I guess for me it's really about arming yourself with as much education and knowledge as you can about the condition, and really finding a way to advocate for yourself and push for to try things, try different tablets if what's working isn't, or if what you've been given isn't working.
Yeah, and that sort of brings me neatly to social media, and I've spoken to two women in the endometriosis social media space in the last week, and both have said that because we've started advocating as women so quickly, and the groundswell has happened so quickly, that actually we've got a challenge with misinformation or disinformation, and in some respects we sort of have to one woman actually said take a bit of a step back and kind of recalibrate, because we run the risk of there being too much misinformation out there. How does anyone look to social media and say, okay, that's who I feel I can trust, and that's who maybe isn't someone I could trust? Again, it's a big question. There's maybe not an answer, but maybe it's something just that you need to be mindful of.
Absolutely. I mean, this is a different age to 10 years ago, 20 years. It's really important for companies, people, businesses to adapt to what we have around us. And the fact is, social media is not going anywhere anytime fast. We've got to find, I guess, validating what's on those platforms. I agree that there is a lot of misinformation and a lot of untruths around not only women's health but other areas of medicine.
Yeah, that's true.
And I think we've got to be really cognizant that what we read and what we see may not always be the truth. In terms of who to follow, I mean, how do you validate anything that's online? There's no right or wrong answer to that, except that you know, if it's because people can pose as they want to pose, and it's down to your discernment and your discretion to really connect with a particular influencer or not. For me, I think that going to forms of education that are outside social media is the best bet. You know, finding as much validated information, validated source, validated platforms as you can. And don't get me wrong, I think we're still trying to catch up with that and make sure that the information that is available is real. But I think if I'm to look at what we need in this space, we need a central source of validated truth. Women are going here, there, information. We need a central repository where everything there is you know, based upon the latest research. It's all validated by clinicians, by scientists, and women going to this central repository will know that that information is valid. And it's something that we're missing. I think technology has a role to play in generating that information available. It's something that we at Bloomful are always mindful of, that we're trying to create information that not only is scientifically and medically sound, but also speaks of the women that are reading it. Written in a tone of voice that makes sense to them, that they can align with. And I think I think we need to move off social media for this type of information, at least for the short term, and try and build this elsewhere.
That's interesting. So again, for anyone listening who hasn't been on the extensive learning curve that I've been on the last few years, that NICE, the National Institute for Clinical, I think it's and Health Excellence, but NICE effectively write guidelines per condition for clinicians to follow when they're diagnosing and treating a condition. So I suppose there are NICE guidelines on the treatment of endometriosis that a doctor will follow. I think I haven't actually read them, but I have read what NICE has said about cannabis-based medicines and endometriosis, which is sort of, we don't really have any answers yet. Painkillers, hormones, surgery seem to be what's going on. Do you think that this is something the NHS should be providing? Because the NHS does now have more sort of consumer-facing information than it historically did. Is that the right place for this to be collated, or is it an independent body that would do it?
So I think it's good that the NHS have moved in the direction of making more information available. They've had to, because the way that it's so under-resourced that they have to make as much info available to people as possible, right outside of hospitals. So I think that's the foundation of that movement. Now, whether or not that is the right place, I think remains to be seen. My feeling is that there's a level of actual distrust in not necessarily the NHS per se, but in the medical community. That amongst some people, like, so for example, as a Black woman, I can say that ethnic minorities in general tend to be less trusting of kind of authority medical figures, just because, like, historically it hasn't necessarily worked for certain populations as well as it should have, and there's a lot of kind of, I don't know, feeling left over from that. People have been left behind in many regards. We know that, for example, women are very underrepresented in clinical trials, minority groups are very underrepresented in clinical trials. That doesn't foster a lot of faith, I should say, in the system. And so I think the answer to your question, for me at least, and that this is just my intuition, is that it needs to be a body outside of our National Health Service that really can speak the language of all women, and act as a sort of almost third-party area that people can access to learn, to understand. And I think the other important point is that we're not doing enough to teach the younger generation about these things. This education needs to start young, really young. Probably primary school, at the very least early secondary school. I think we need to start teaching. Our bodies are what we carry around with us, and I think we need to start being much more proactive about teaching not only girls but boys about these conditions, what effect them, how to advocate for yourself in the medical thing. I've got two very young daughters, and I'm very intentional about teaching them about their anatomy, for example. I don't use funny words. I don't kind of baby lingo to describe different areas of the body. Same with my son, by the way. I'm very kind of, this is what it is. Just like
this is what it's called.
And I think we need to start bringing that into our everyday language, and I think that would solve a lot of other problems outside of health as well, like societal problems around
so that would then look like a body that the NHS would endorse. I'm just going to tease this out a little bit more, and then I'll leave it alone. So something that the NHS would endorse or be comfortable with, and that perhaps some leading clinicians would say, we also recognise that as being sound information that's being provided, and it would be scientific work but presented in digestible formats and accessible to everyone, so that we can all sort of educate ourselves as much as go to experts, whether they be social media experts or very technical scientific experts.
Yeah, absolutely. And I think it's, the beginning of the spectrum is just information written, like it is on the NHS website.
Yeah.
I think it's difficult for our brains to conceptualize what that tool could really look like.
Yeah.
With the advent of artificial intelligence, with the tools that we have available, we could be creating some really, really great assets by bringing all of this information. Yeah. And I think, having things in different languages, for example, available to people with other visually impaired people, definitely, there's so many gaps, there are so many things that we just don't, that put women at a disadvantage with this stuff. So I think there's a lot of scope there for a tool like that.
Yeah. Fascinating. I'm not going to say we're going to do it, and I'm not going to say you should do that, but maybe someone will do that. And my final question, I want to go back to the macro, and this is from thinking about the trial we're doing and my obsession, which is getting medicines available on the NHS. So cannabis-based medicines available on the NHS, because while cannabis-based medicines are available only privately, it's, again, if you can afford it, you'll find someone to prescribe, but we need these medicines available to everyone who needs them, not just those who can afford them. So our focus is obsessively on gold standard randomized controlled trials, clinical trials, double-blind crossover, all that stuff, so that we can convince the MHRA and NICE that these formulations are safe and efficacious. And as I have also learnt, not only clinically efficacious, but the health economics stack up as well. So the NHS can say, yes, we can afford to fund your medicine because it means that we won't have to do invasive surgery, or we won't have to give this patient some other drug in its place. So that's our obsession. And I talk often to people in other jurisdictions about their regulatory environment and their healthcare frameworks. And I realise that as much as we get cross about the NHS, there aren't many places in the world where we have this incredible ability to say, if we can get this drug on the NHS, everyone can either have it for free or at a reduced price. If I talk to people in the US, they just, they're jealous. Yep. So I sort of, maybe I'm thinking I need to finish on a high, I'd like to finish on a high note, that sometimes it's really good to think about the positives of our system, so at least we can focus all our energy into this NHS and say, right, that's our target. What, in your experience, not only in women's health but more generally, have you come across that as well, that we take it for granted and we bash the NHS a little bit, but then actually when we step back we go, oh, it's not so bad, or it's still okay?
Absolutely. I think I alluded to it actually at the top of the show.
You did.
That I think we're kind of an instant gratification era of life, and I think people want what they want now, and that is fair to some degree, but I think it means that we lose sight of what we have in front of us, which is the ability to access care that is free at the point of need. That is amazing, and there aren't many countries where that is the case. Only a small percentage of people in the UK have health insurance, and it's usually through your provider, or if you're financially able, there are people that do it privately. But the fact that anyone in this country can access care, whether they have insurance or not, is really, really different to many other Western nations, notably the US, where I think the system needs an overhaul, frankly, because it's a hugely disadvantageous system for people that are poor, disenfranchised, socially isolated, even geographically isolated. I think we need to be grateful for these things. I think that for all of the negative sides, I think there is a lot of potential still within the National Health Service. I do think it needs to evolve to match the needs of our population and population size in comparison to how it used to, who it used to serve and how it used to serve. I don't think it necessarily works in its current form, but I think there is an iteration of the NHS that I can see in the future that will and can work, and the basics of which are the same as they've always been, which is to deliver care to a nation free, essentially, or obviously we pay,
unbelievable,
and make care available. I think that's a really great thing.
Yeah, yeah. Well, on that note, I'm going to say thank you very much for your time. It was absolutely fascinating. Dr. Dupe Burgess, thank you very much. And I'm really looking forward to talking to you again soon as we develop our work and as you develop your platform.